Item number 5, and that is our integrated performance and quality report. And as is tradition, I'm going to hand over to David, who will work with colleagues to take us through the report, and then David will manage questions at the end as well. So over to you, David.
Thank you, Sarah. Good morning to everybody. And it's my pleasure to present the IPQR report for you to this board. Just a reminder for colleagues, this isn't a standalone report, but rather a compilation report that is built up from the data and reporting that goes into the subcommittees of the board. And then for that to be a subset of that to be collated for a wider board view. I suppose it's worth pointing out, recognising that a number of the chairs of the subcommittees have changed in recent times. I would encourage you to work with your executive leads and our performance team to ensure that the reports that you're getting for the subcommittee are appropriate for you. And secondly, that the selection of reports that we bring to the board and collate would be the salient metrics from the subcommittee that would be relevant to share with the rest of the board. That's an ongoing review, and I recognise that the priorities for the subcommittees may change during the year, and it would be entirely appropriate to change the selection of reports that would come. In terms of the content of the report, the couple of highlights for you, I would say. I think it's fair to say that it's been fairly challenging for the board over the last few years across a number of our metrics. COVID has not helped and has been a major interruption in terms of our performance and recovery has been very much the focus of our performance. And there are green shoots I would like to suggest to you within the report today. It's interesting, fellow colleagues are sometimes reticent to celebrate success too much because it could all go wrong tomorrow. But I would like to say that there are some recovery and sustained recovery. I think 2 areas in particular I'd like to draw your attention to is on page 180 of the papers in relation to CAMS. And also page 190 related to psychological therapies. We really have had sustained improvement over the reporting period that you can see, where our over 18-week weights have come down in the region of about 40% in each of those 2 areas. So the improvements might seem on an incremental basis, month by month or board by board, relatively small, but you can see over the sustained period of time that continues to improve. So I think that is worthy of mention. Another area of focus, I'd like to just give you some updated information from what is in there, and that's related to our cancer performance in page 186. In the report in front of you, you see that the 31-day performance has improved as it's gone reported in February. If I can, I'm going to give you the March and April numbers for 31 days. And it was at 97.3 as we reported in February, 92.7 March and 94.2 in April. So a high performance being sustained over those 2 months. But probably most significantly is if I look into the 62-day target, we have had significant challenges around that. And we did give an indication last board that we had started to see these green shoots. So the March number has improved from the 57.6% in February to 67.8% in March and 71% in April. So we're definitely starting to see that improve. We do recognise that in the treatment of cancer, it does depend on very specialised care, and it can rest on individuals and individuals being available and in post. And so therefore it is subject to variation, but nonetheless, the last 2 months have seen significant progress in 62 and a good degree of stability around 31 days. Two more things for you. When we look at outpatients and TTG, we did present to our MP and MSP colleagues on Friday an update with regard to our scheduled care times. And actually, I felt that the presentation that Catherine shared with our colleagues was actually very helpful and actually would be useful for the board. So I have circulated that rather separately. So you'll see that, and it shows over a longer horizon in terms of our recovery against our waiting times. What we will do is look to use that similar type of format for future reports, in the first instance coming to the FB&R committee, and then secondly coming to the board. So if I could ask you to have a look at those in addition to what you have in front of you today. Finally, I noticed from the board action report, we were to submit recovery numbers and trajectories for radiology. They are not in this board paper, but we will see those numbers in the report that will first go to the FB&R committee next time, and you'll see that in the board. So that will be able to close that action out. I think that's all my comments initially. I'm happy to open up to questions and then call in my colleagues as required. Thank you. Alistair, Christy.
Yeah, thank you, David. Good morning to you. I just want to echo the point you made. There is a lot of good news in this report, and we do not, as a board or as an organisation, often publicise or tell people of the good news. And I think perhaps it would be interesting to know if we could actually have some media strategies, because there's a lot of information in this report that people in Highland would like to hear about and would be delighted to hear about, because it is good news. There's also areas that are more challenging, but it would be nice if we could think of ways where we could get the information out there. And I'd welcome any colleagues' thoughts on how we might do that. I suppose as usual, I want to focus in on the cancer statistics, and I think the performance of 31-day target is excellent, and the additional information that you gave shows that we're still hovering around that mark. The 62-day performance, I was perturbed when I saw it at 57.6 in the papers, but from what you've said, going up to 67, and I think you said to 71 in April. That's interesting. That's really pleasing to hear. It would be interesting to hear from colleagues as to how we can sustain that trajectory of improvement on the 62-day performance. And one thing that's not I can't derive from the graph is how many patients does it take to move it by, say, 1% or 2%? Is it such now that on the 31-day performance that we're actually dealing with small numbers of patients to move by the 1% to get it over target, which in turn will make it harder to deal with? So I don't know if there's anyone got any insight into that information, but overall I still like the format of this report. I think it's excellent, and that's my contribution. Thank you, David.
Thank you, Alistair. Catherine, can I come to you on the cancer questions, please?
Yeah, sure. Alistair, I can't give you the specifics in terms of obviously that 1% and what that gives you straight away. We haven't looked at it through that lens, but I'm more than happy to take that away and come back to you following the board meeting. In terms of the trajectory, though, and the sustainability of that trajectory that David's described, as I've discussed at previous board meetings and in development sessions with you, there is a huge amount of work going on behind the scenes to try to unlock this and ensure that our performance around cancer improves. You'll be aware that Lorraine is working within the team currently, and that is really good. What Lorraine is doing is working across all the specialty areas, particularly the challenged specialty areas, and those in particular are urology, colorectal, and dermatology. So we've got a particular focus on there. And what we're doing to ensure that we can sustain that is cancer has to be prioritised. Now, sometimes within the intricacies of the booking processes and the arrangements around that, it can sometimes mean, and the fluctuation in demand, as I'm sure you can understand, we sometimes need to be rescheduling arrangements for patients to ensure that the prioritised patients get seen first. So that's the detailed work that we're doing within the service areas to ensure that, and obviously looking at capacity as well, to ensure that we do have the capacity to deliver. That's challenging sometimes, particularly with our workforce challenges that you're well aware of. And so in terms of that, it's about working beyond our health board boundaries with other health board areas to see what we can do, working collegiately across not just the northern region, but across Scotland as well. Thank you.
Thanks, Catherine. And I know cancer services are particularly close to our medical directors, Purvi and Boyd. Do you want to add any further comment?
Thanks, David. I think Catherine's covered a lot of it. It is looked at regularly by the Clinical Governance Committee. So there is a route up to board through there. The thing perhaps for board members to note is that cancer is not one entity, but it is multiple departments involved, and it's multiple steps in each cancer pathway. So it's actually very complicated, and it's one of the reasons that we've got not one but two cancer oversight meetings, one operational and one more strategic. And so you can be performing very well across lots of departments, but have one or two hot areas. Catherine's mentioned, I think, 3 or 4, where there are particular challenges, and that can affect your overall results in the way it's presented here. We look at more detail in the Clinical Governance Committee, therefore, as a result of that, and in the several cancer meetings that I've described. Thanks, David.
Thanks. Louise, did you want to add further to this part?
No, slightly different, thanks.
All right, okay. Thank you. So thanks, Alistair, for your question. Susan, can I come to you, please?
Thank you, David. And I want to join Alistair in encouraging you to get some of that good news out there, because I think there is an awful lot in here that people would welcome being able to access, and the report itself is really useful and helpful to us. I'm pleased to see that we've included more of the comparative data with other boards. It was something that had come up at our governance discussions development discussions we'd had. But I'd be interested to know, how do we use that data? How useful is that to you in planning and bringing about the improvements that you want to see across the piece? Thank you.
Thanks, Susan. I mean, I can talk at a general level, in certainly in the discussions I've been involved with regard to that. I think it sets as to whether our local challenge is just a local challenge, or it's seen very much in an aggregated way. I think we've seen our teams make connections to those who are, let's say, high performing in those spaces, and therefore it allows us to ask the question, what are they doing so well that we are not able to attain? Sometimes that can be around resource, and sometimes it can be around technique. But the Centre for Sustainable Delivery is actually a key element to all of this, because they too are looking at the national data and comparing boards and engaging positively with all boards in terms of what's going on and how to use that benchmarking in the best way. So it is a real opportunity, and something we're likely to see even more of going forward. But it's a very useful tool. It's not, you know, I don't get any sense of complacency when we look at it from a national point of view, because that sometimes can be the downside. I don't get any sense of that, because we recognise that to achieve the targets or to maintain the targets takes a significant amount of effort, as been described earlier. But there are some areas where, although we might be performing reasonably well, we're always aspirational to perform better, because actually we're still below target. So it's a useful reference point, but that's is the starting point, as you've described in your question, to, okay, now where do we go from here? Thanks. Alex, can I come to you?
Yeah, Thanks, David. Yeah, I agree both with Susan and Alistair about the fact that it's positive, and we've got a lot of positive figures, and that's great. And it's something that should be celebrated, and we don't celebrate it enough, and we certainly don't celebrate it in public enough. And it's something I think we need to think about how we're going to do that. Having said all the positive bits, now of course I come to the couple of questions which aren't quite so positive. Tim, on the screening numbers, do we have a handle on why the NHS Highland numbers seem to be going down, apart from one, seem to be getting worse over a period of time? And is that a trend that we suspect will continue, or have we done something to up it? And then on the delayed discharges, again, the trend seems to be going the wrong way. Is that primarily because of the issues with care at home and care homes in the Highlands, or is there something else that's a factor within that? Thanks.
Thanks, Alex. Tim, can I come to you first, please?
Yeah, I think, thanks for the question. The main area where screening performance has deteriorated on the IPQR is in aortic aneurysm screening. And a lot of work has been done. There have been capacity issues. The screening for aortic aneurysm is done by ultrasound scanning, and then that's then moved. Once that's done, then there is potential activity involving vascular surgery, and both those areas have some degree of capacity challenge. There's been a lot of work done in addressing the system with an aortic aneurysm screening, because unfortunately the figures presented, certainly for screening, tend to be annual. So we're a little bit behind the curve on what is actually shown on the IPQR. Performance initially was poorest and was addressed in Argyll and Bute for aortic aneurysm, and that's got a lot better. And now we're looking at the turnaround within Highland, which wasn't North Highland, which wasn't as, the situation wasn't as bad, but deteriorating a little. But I think that whether it has turned around, I think it's just about started getting better. But overall, we're certainly we're not looking at a continued decline in screening performance. It's more individual issues that are being addressed, and I think certainly for aortic aneurysm that'll definitely get better. So I think it's right to raise the concern, but I'm not. I think there's some good work going on to mitigate the problems.
Thanks, Tim. And Pam Cannon, can I come to you? And recognising that delayed discharges is a challenge in Argyll and Bute also, but I think the largest proportion of delayed discharges stay in the Highland region. So if I can come to you, Pam.
Thanks, David. Yes, we are experiencing an increase in delayed discharges since the board received the IPQR at their last meeting. We have increased, and at that time we were looking at the impact of Castle Gardens closure and what that would mean on the system, and we really feel it in the system that's the one that has kind of pushed us into the higher numbers, where we've reached a point where we're quite stuck in the system. So we've got delayed discharges within our acute and community hospitals within North Highland, and also we're looking for new care home placements for people in care homes who have been affected by closures, mainly from HC1 organisation pulling out of their care homes. So it's a really difficult space that we're in just now. There are some good news on the horizon though. We're looking at some commissioning work to do with care at home to see if we can create more spaces for people so that we can move people through the system more. Also in terms of our joint strategy that we're developing, we're looking at transforming some of our services and looking at how we jointly recruit staff with the independent sector, which might give us better recruitment and better retention of staff. We're continually looking at how we use unoccupied care home beds. So some of those may be for self-funding patients self-funding people. So we're actually working on individual cases to make sure that we can get people into beds and get occupancy up as far as we can. So it's an ongoing problem. We have lost 141 care home beds over the last 2 years, and we're really seeing that replicated in our system. So that's really positive. One piece of good news that we have received is that Cradle Home Care Home, which is one of the HD1 homes, it's been bought over by another provider. So that gives us some sustainability in terms of the people who are residing and receiving a service in Cradle Hall. So that's good, and that's something positive in terms of the sector, because in the last 2 years, all we've been experiencing is a lot of the independent sector pulling out and not being able to cope in the current economic and financial challenges. So that's a piece of positive news. So maybe the trend will change. Thank you.
Thanks, Pam. And certainly from my experience, the interruption and the disruption, rather, that changes in the market cause has a ripple effect. So obviously, if the priority is to rehome people from an existing home, then those spaces that would normally be allocated to people coming out of hospital, for example, are no longer available to do that. So it does normalise over time, but when you have that disruption, it will cause a bump in the road as we go along, which has a major knock-on effect. But nonetheless, it still is one of our most challenging areas for the board, and the fact that it has such a knock-on effect to all our other services that we provide. Louise, can I come to you?
Yeah, I just wanted to reference a couple of things around the data from clinical governance. Boyd and I are working hard with the team in the background to actually go to the next step with this data. So clearly we're in an improved position as in what we can get and what we understand now. And it's like the so what, really? What is the data telling us, and what's the next level of what we actually want to see and achieve? So there's work going on in the background around that. But also we hope that we can get some charts that will give the picture of the work that's going on and really understand what that means for the services in the future. So I'll give the example of the graphs that look at inpatient falls, for example. There's a differential in terms of the blue and the black. There isn't necessarily a descriptor yet of what that means, and we're going to change that so that it's much clearer what message we're trying to give and what improvement methodology we want to progress that. So I think we're getting a real handle on the data now and understanding what we're trying to say and what we need to achieve. Also, just your reference to celebrating positivity. At the last clinical governance, there was reference to the fact that although on occasions in our infection control data, we haven't quite achieved the national target, we have been very close, and given the challenging position that services have been in, that in itself is a positive, and it is part of a direction of travel. So I think even when teams haven't quite achieved what we're required to, I think we still don't want to see that as a negative, because that doesn't help us progress.
Thanks, Louise. That's helpful. Sarah.
Thanks. One thing that I'll maybe take offline, and one other matter. So just back to the 31 and 62 day cancer targets. Obviously, this is a challenge and a focus nationally. Really delighted to see those improvements in the 62 day target. And what I'd be interested in looking at offline, because I will be asked about it elsewhere, would be how we have achieved those improvements. And back to a point that Alistair raised, I suppose what our plans are around sustaining that. So that's something I'd like to take out with this meeting. But I just wanted to pick up, and I'm sorry I don't have the page in front of me, but it's the very nice colourful box that shows us the instance data SAERs. I noticed where violence and aggression incidents is on that colour map now, and I just wondered if perhaps Boyd or one of the other colleagues could talk about that. Clearly that's a worrying trend. I know it's not new on that graph, but I think it's kind of moved up in terms of the size, the proportion that it's taking up. So I just wondered if somebody could talk about those violence and aggression incidents and what we're doing around that. Thanks.
Thank you. Thanks, Sarah. Boyd, can I come to you, please?
Thanks. Yeah, I think the first comment is, I suppose the IPQR attempts to capture and express in a high level way something about the whole system. The side effect of that is that you get something like that where you can quickly read into there's a lot of violence and aggression. But actually, I would ask the board, first of all, to be patient. We're going to change that. Because what it does is it misleads all of us to think the headline terms are what's happening. I would reframe it that a lot of that data in that box actually expresses how when people are ill and confused, as can happen to patients, they will have symptomatic distress that includes in their confusion things that have, through a software system, ended up classified coming under that terminology when it's actually a symptom of their illness and something which healthcare professionals are trained to manage, but which they might report into our safety system and therefore appears in data. And so I think we will be, as Louise has said, we will be developing some of what you see to kind of give you a better idea. But of course, at board level, will be very high level. And what really will matter is, as I've just described, that we kind of look for where that is a particular issue, and do we have the right staff training and preparation, the right environment, etc., to help in those circumstances, and what else might be helpful in that circumstance. So that's a fairly general, but I hope illustrative and illuminating response, and it will be something which we'll report in through Clinical Governance Committee as we develop something that's at the further down in a more detailed level in the data tree, and perhaps better connected to patients and symptoms as described.
Thanks, Boyd. Louise, did you want to add something to that?
Yeah, just briefly, in relation to how we report, I think there are certain things that people absolutely routinely report, and those always come up in those high boxes. And I think we need to ensure that we've got a reporting culture that captures everything that we would see as an incident or an adverse event, because I think there's things that people sometimes accept as slightly the norm. For example, staff availability, the numbers on the chart are very, very low. We know there have been challenging times, and I'm not sure that is always captured. So I think there is something about making sure that we're supporting people and giving them the space and the ease of access to the systems to consistently report everything, so we don't sometimes end up with a slightly skewed picture. I'm not suggesting it's entirely skewed, but certainly the fact that falls are very clearly something we report, violence and aggression is very clearly something we report, and you look at the other end where there's probably under-reporting.
That's a useful point, thank you. Bert, can I come to you, please?
Thank you, David. A couple of questions under clinical governance. One in relation to DATICs and one in relation to SAERs. These are things that have featured in this kind of report to previous board meetings. So in relation to DATICs, there is an acknowledgement that there is a backlog, if that's the right word. I think, if I've read it correctly, there are 2,117 reports awaiting review, and work is underway to try and deal with this. I wonder if there's anything that can be offered to explain, how does this backlog arise? Is it about capacity? Is it about focus and prioritization? And I suppose linked to that, there will be risks about important things being missed if we're not able to deal with them in a prioritized way. The SAERs, I think we've heard previously that the reported numbers remain low, and it gives rise to the question, I think, about the categorisation of them. I'm wondering if any progress is being made in terms of resolving what's been said previously about it, and I suppose some assurance that any perceived miscategorisation does not adversely affect the prioritisation or the investigation, the depth of the investigation. Thank you.
Thanks, Bert. Boyd, can I come to you for this, please?
Yeah, thanks, David and Bert. So a two-pronged question. The first one on Datix. Louise has just referenced logging of incidents. So anything that's logged in Datix is unfortunately then collected and called an adverse event, but is actually an incident or a loggable item or occurrence. There can be positive ones as well, of course. And so the numbers simply indicate that we have got a fair level of reporting, albeit that doesn't tell you if everything's reported everywhere all the time in a truly switched on antenna-like system, which is what I think Louise's point was. Therefore, you see the numbers, and what I think you're referencing is where the pattern of red not yet reviewed Datix has slowly over a period of time increased, and you can see a red at the bottom of the graph in the relevant slide, an increasing amount of red at the bottom of each column on a monthly basis. So that's been noticed, and the chair of clinical governance has written out. We've asked in the clinical governance committee that this be reviewed and looked at to understand better why, and also to rectify it, because exactly as you say, it's a really important thing. And if you're not looking at all of the stuff that comes in, you might miss the one or two high level things. Now we would hope we wouldn't, and that high level things were reported by methods other than Datix. Datix is a completer finisher act, whereas for something big, there are other escalation routes which will happen. However, there is a risk, and therefore it would be right and proper to minimise that red section at the bottom of that column in data terms by things being reviewed in a TIMIUS basis. That's the reason why it's changed like that. I wouldn't presume to say exactly. I have theories like others in committee had, but I think we'll wait to be advised what the reasons might be. It might be system pressures, it might be something else, and we need to establish that. On the ASERs, the numbers are as stated, and what we have now is we've built up a system of more rapid case review, so that you have a more responsive and rapid case review of many cases, which then don't end up in a queue awaiting SAER. An SAER has got a completion target time of 6 months, which gives board members an idea of the amount of work that's anticipated even in a quick one. And so in some cases, an SAR takes a lot longer than that for a whole variety of reasons, often complexity and multiple staff and personnel involvement, and the difficulties of coordinating that. So by doing more of the case reviews, we find that allows better concentration on the SARs where a real in-depth and formal look is required. And these case reviews then will report in through our clinical governance routes, and we are seeking to understand a bit more about those. It may be that in future data emerges that helps us see that bit, which you don't see in the slides that we present today.
Thanks. Pam Cayman, did you want to just add to this part of the discussion?
Yes, I was just going to add to this part just around the Datix awaiting review, and it just goes back to the earlier comments made by Boyd about the type of people receiving care. So a lot of these, for example, arise in the mental health and learning disability service, particularly in the learning disability service. One area is a type of restraint that's also part of normal care planning applied to that person's individual care. But they have to be Datix, and I think there had been a time when these weren't being reviewed because they were accepted as part of another quality process in terms of their care plan. So we've been able to realise that, and we're addressing it now, so we should see them being signed off as we go forward. But we do need to think about the different categories that we have within our reporting as well, because they all go on as under the violence and aggression heading. Okay, thank you.
Thanks. And it might be that the Clinical Governance Committee might give an update in some of the commentary of the IPQR coming back for the next time, given the comments around that and the investigative work that's going to take place, just to try and get under the bonnet of that rising number. That would give assurance to the board. Thank you. Muriel, finally, can I come to you?
No, thank you. Just going back to the start of the questions, the communication and the positive communication of the achievements achieved with some of the targets, but notably the cancer targets, is great. But I would ask for considering or consider a note of caution. We have other modalities, surgical specialities with very long waits, and patients, clients are being told 18 months, 24 months wait. So it's managing expectation, and maybe that's something we could pick up at the Clinical Governance Committee. So yes, we must note the good work that has been undertaken by everybody in the team, our teams, to achieve those targets, but we've got work to do in other areas. Thank you.
Yeah, thanks, Muriel. I think it's always good to acknowledge progress so that our teams can be encouraged to continue their recovery plans. It can be quite a difficult system to work in, where you're always managing by exception, and therefore you're always looking at bad news. So from that point of view, it is good that we're able to give feedback to the teams who are making progress, recognising progress can need to be sustained over quite a long period of time. I think we can probably celebrate better once we start hitting targets. And that would be a time to celebrate. But equally, every target you hit, you have the added piece of, well, how come you're not hitting it in the one that I'm waiting on? It's one of those impossible things to get right. And so I think your comments are helpful, but it also reflects how difficult it is to get the right balance. But I see Ruth has got her hand up, so she might have the answer that I don't. Ruth.
I wish it was quite that straightforward, David, but yes, I've heard the comments around acknowledging some of this positive progress, and certainly now that this report has been to the board, we'll be able to pull out some of those aspects of it and create some communications around that. Now, with our communications, we always strive to be a strategic function, so we want our communications to be supporting the outcomes that we're working towards as an organisation. So we want to put out good news, yes, but we want to make sure that good news is supporting an outcome, whether that's encouraging recruitment, supporting staff morale. And I think in this case, the point Muriel made is really valid. There is something as well about ensuring that the public have access to easily understandable and digestible information about our performance, and that we're being really open and honest and clear about how we're performing against our targets, and perhaps in relation to other boards as well. So my team will be taking a look at this report and looking at how we can take information from that and display it and share it in a way that supports those aims. Thanks.
Thanks, Ruth. That help would be much appreciated, I'm sure. Okay, thank you, colleagues, for all your questions. They're always very helpful in making us double think everything that we're looking at as the executive team. It's really useful to do that. And as I say, the report today is put forward for moderate assurance, and it shows that it's very much still a work in progress, but there are, as I say, some good news in the reports, as well as still some challenges. But with that, I'll hand back to the chair. Thanks, Sarah.
Thank you, David, and thank you, colleagues, for those questions and those updates. I think that's been a really informative and stimulating discussion. And as David said, it's always good to question our own assumptions and rethink what we think we know, and I think that's the usefulness of the report coming to us in this way. And just to reflect back on comments from Muriel and David and Ruth, I think absolutely, that balance is a tricky one, and I suppose that those two truths are reflective of the complex and pressured systems that we're working in, and there is there's an important dance, isn't there, around kind of celebrating and incentivizing and really showing when people are doing some really great work, because there is some fantastic work going on, but equally making sure that we are on a journey of continual improvement, and that our patients and our communities and our staff have ways to engage with us when something is not quite right, so that we can keep working on that. So I really welcome that discussion today. Thank you. So yep, as David recapped there, being asked to take moderate assurance and note the report, the continued sustained stresses facing both NHS and commissioned care services, and note the addition of the trajectories where available, and that the ADP, the annual delivery plan, and the winter plan continue to support mitigation plans where possible. Are we all happy to do that? Fantastic. Okay, great. Seeing some thumbs up. Lovely. And we even just a minute over time. Fantastic performance. Great. Okay, so that takes us on to agenda item number 6. So this is our finance assurance report, and I'll invite Hilleth in to speak to this. So this is our month 12 draft position and our financial plan for 2023-24. So I will hand over to Hilleth, please.
Thank you, Sarah. Yeah, as you said, this is a report that's in 2 parts. So it's looking backwards at our financial performance for the last financial year, and is giving an indication of our financial view for next year, for this year now, sorry. I'll just go through this briefly. A lot of the detail is in the paper and in the appendices. I'm happy to take questions afterwards, but the main points to raise on the month 12 position is that our closing position, subject to audit, is a deficit of 15.891 million, but that's before the use of brokerage, which we have to formally request from Scottish Government. Due to deadlines and the need for allocations, etc., we have written to Scottish Government to request that, and this did go through FRP committee as well. So we've sent a letter to formally request the brokerage of 16.272 million, which actually reflects our planned opening gap. And we've had that confirmed as well, subject to repayment of brokerage at a point where we're financially able to do that, but further details to follow that. So I guess what we're asking the board today is to approve stroke ratify that request, which, as I say, was supported at FRP. The main movements from the month 11 forecast that we had is an overall improvement of 4 million, and that's broken down roughly into the acute position deteriorated by about 700k, but then the North Highland Health and Social Care Partnership improved by the complementing amount of 700,000. And then the 4 million improvement was all within the corporate services, which was there was a slight improvement across all of the corporate services, but it's predominantly due to additional allocations and national adjustments and national contracts that we had. Within the position, just to confirm, that does reflect a break-even position for adult social care with the use of reserves that we had. And equally, Argyll and Bute's position is a break-even position, but they did report a small surplus which they can carry forward within their reserves into 23-24. Savings, we delivered just shy of 10 million of the 26 million target, but much of that was non-recurrent. And then within section 8.4, we've just given a breakdown of our financial improvement from the month 5 position, which is when our position originally deteriorated, just to show how we've then recovered that position back to the similar to our planned position. And you can see from those actions that actually the majority of that is non-recurrent actions. So they're either additional allocations that we've had or improvements, or they are balance sheet adjustments that we've been able to make, and we've effectively cleared out everything that we potentially benefited from during COVID reserves and allocation that we had. And just to confirm that those that were not non-recurrent, we've already played into our 23-24 position as well. So that's already shown within there. And then finally, just to say within our capital allocation, all of our allocation has been shown as spent. And as we've heard earlier in today's meeting, the majority of that investment has been on the NTC. I will move on to the 23-24 plan. So there is a small change from the draft plan that we last submitted, the first version. So we're now at the final plan submission presents an opening gap of 98.172 million deficit with a cost improvement target of 29.5 million. So that reduces that gap to 68.672 million, which is clearly a significant amount. But we did have to provide a 3-year plan as well. And over the 3 years, it does show a further deterioration. And that's predominantly due to inflation assumptions and income uplift assumptions that we use. They're the two main variables, I suppose. So we could see improvements in those inflation assumptions. We could be a little bit prudent on those, and we've also been prudent around our assumptions on income uplifts that we would get as well. So they play into those future looking years, which we have less information and detail on, just the way that we are funded. And we also don't have longer term views on the expectations from our performance either. So it's very much a financial analysis. Scottish Government's response is that they have written to us to say that they will provide us with tailored support. And the intention of that is to assist us to develop and implement a robust financial recovery plan. They've presented this as a 4-stage approach, which includes diagnosis, planning, delivery and implementation. We haven't had much information around that as yet, but the deadlines that they've given, or the timescales that they've given at the moment, is that the initial diagnostic kind of phase would be complete by the end of June. We've provided them with a lot of information on our planning assumptions, our savings plans, various detail on our spend and where it is. So they're trawling through all of that as we speak. And hopefully I'll have a meeting with Scottish Government colleagues within the next week or so. And then the view is to have an agreed financial recovery plan by the end of September. So as I said, there's no further detail on that at the moment, but they're very much looking at how they help us and support us to deliver what we need to deliver, but also to be able to maybe look at some areas where nationally we can learn from or get some learning from colleagues. Within our position, our current savings approach is to work with our services, look at opportunities, looking across the 3 horizons. So what can we do in year 1 around releasing efficiencies versus the longer term change, and around that, what infrastructure and support we can wrap around these to drive and monitor any plans or changes that we need to put in place. So happy to take any questions from that. I guess to note that the 2 decisions that we're asking for is just a confirmation on the brokerage and to, I guess, approve the 23-24 plan, but that is recognising that could vary and change as we work with Scottish Government. And happy to open that for any questions.
Thanks, Hilith. Clearly this will have been scrutinised in some detail at our Finance, Resources and Performance Committee, but I'm happy to open up for questions, comments. I've got one, but I'll see if anybody else wants to come in. Okay, I'll start off and it might stimulate some other discussion. So obviously that is a sobering message around our finances, and I'm interested actually in how that message is, I suppose, suppose, more widely for our colleagues, our staff, our partners, and the other people that we're working with. I did notice in one of the papers, and I'm really sorry, I can't remember which page number it was on, but there was reference to some new resources being put together for budget holders. I think it was a budget holder handbook or something to that effect that I saw in one of the papers, and I just thought that was great. But it did make me think, and I wonder if you could say a little bit more around what we're doing in terms of our approach to engaging and working with our staff and our budget holders around this. Clearly, it's going to be a difficult message to be putting out throughout the organisation and to our partners, recognising that there's also some added uncertainty around, where we are with Scottish Government and their kind of how they're going to work with us on this. So I just wanted to hear a little bit more about that work around the handbook, the resources, and I suppose the culture of our financial improvement journey and how that looks throughout the organisation. Thanks.
Yeah, I'll start it, but I'm sure that some colleagues will happily join in and give their views as well. But from a communications messaging point of view, we've had an event already with execs and deputies around partly the financial position, but mainly our action plans generally organisationally, and where we need to focus our attention, what our priorities are. And hopefully that would then feed out into the financial information. So that session did give the stark message around the finances. What we need to maybe do is work on how we filter that down throughout the organisation. We do have finance business partners who work with the budget holders who should be having those conversations. Those messages will be shared at local senior leaders meetings within the different areas. The point on the budget holder packs, etc. I think the paper you're probably referring to is the internal audit that was on finance and performance accountabilities. And one of the things that we'd said there is that we need to put a bit more support into that financial training. I think just during the last few years of COVID, some of that higher level training has probably dropped off. There's a lot more one-to-one work that's been happening with the accountants and managers, but that would be on detail of each individual areas of spend rather than looking at the global picture, I suppose. So we do need to probably do something in the communications around our position going forwards, which can be done. And then the budget holder pack was more around the accountability piece of things. So making it really clear to budget holders what we expect of them, what their responsibilities are, but also what they can expect from us as a finance function in supporting them to deliver that. And with accountability agreements and various things that people have to sign up to give their commitments to the financial position. In the budget setting process for the future year, we're trying to be a bit clearer around what that budget position looks like. It's really difficult when you're in a deficit position to give a budget, because if you provide a budget that is expecting the higher level of spend, you're kind of given authority to spend, which is not what we want to do. But we do have to recognise that with the current spend trajectory, that spend is there. So if you give someone an unrealistic budget where it's much lower than you're expecting them to spend, then they're not going to hold that or feel accountable for it either. So there's a balancing act there, and we're trying to work through how we reflect that best within budgets so that managers have a realistic amount of budget to work with, but also don't think that the budget amount that they have is an amount that just go out and spend regardless, and that actually does put us into a deficit position as a board. So that's a fine line. I'm not sure if there was a part 2 to the question there that I've missed, Sarah. Apologies.
I can't really remember either, so that's okay. But I can see that Pam Crowman had her hand up, and I wondered, Pam, was it on this that you wanted to come in?
Yes, thank you, Chair. It was just to tell you a bit about the work that we're doing in the community services. So in line with the development session that we had with the execs and the deputies, we've taken this to the senior leadership team. So we've already had one development session around the adult social care cost avoidance plan. So it's got a supportive narrative as well. And we've also had a session on primary care and primary care putting forward their savings. So the work that's being done on the Horizon template, then we already have those savings into the template so that we can start to monitor going forward. And this Friday then we're going to collate our savings and transformation plans around mental health, community and in some of our hosted services. So we are monitoring this through senior leadership team. We're coaching through our community senior leadership team. It's quite clear that up until now, maybe the staff have done quite a bit of housekeeping, you know, in terms of financial management. So we're trying to take them into a new space in line with the joint strategy that we're developing with the Highland Council, and we are looking at our transformation plans, and we're also addressing some ongoing things. For example, we've discovered in vacancy management that we need to maybe apply much more scrutiny and leadership to that process. There seems to be a lot of additionality and maybe spending up to budgets without thinking of the transformational change that we need to take forward, or the horizontal integration that we might want to do across the districts. So we're certainly doing a lot of development and leadership work with the staff teams to try and get them into that place, you know, and improve their financial decision making and their financial planning and their savings and efficiency plans, and their application to that going forward. Thank you.
Thanks, Pam. Okay, I'm going to bring Anne in now.
Thanks, Sarah. I've got 2 or 3 questions. Just the first one's just a more detailed one, Heleth, on the recovery plan for last year's position. So that the recovery plan that we proposed had initially a fairly significant contribution from technical adjustments and increased cost control measures. And I noticed that in the end of the day, I think there was only about 1.5 million of the initial 10.5 contributed to the recovery. I wondered if that was because it was found in the end of the day that those measures weren't possible, or whether they were not needed and are therefore available to support this year's position potentially. So that was my first question. And the second was around the adult social care position in Highland and how that impacts on our overall position. Again, arithmetic, never my strong point, but it seemed to me that when you take account of the non-recurring support this year and the savings expected, etc., that we're looking at a recurring deficit there of something like 18 million, a gap of something like 18 million. Is that correct? And if yes, I just wondered, I don't think it was in this paper, but always we're thinking about how our position compares to other boards across the country. And I seem to remember that in comparison with other boards, our position was, you know, reasonable. Well, I think we were in, I don't know if you would call it the top 5 or the bottom 5. And I just wondered if that 18 million is reflected in that position, and you know, if we weren't in the lead agency model, if that would have a significant impact in our overall national position in comparison to other boards' financial plans for this year. If you see what, hopefully I've explained that. And then lastly, then this is a very much larger point, and I suppose maybe even directed to Pam. I noticed with interest in the national efforts the national work streams, there was a lot of reference to pre and post-COVID. And with the scale of the challenge that is facing us, and thinking about our 3 horizons possibly stretching, you know, to 8 to 10 years, we're not going to address this other than through significant transformation. And I just wondered whether at a national or local level, we're yet able to fully understand what exactly is happening within our system in terms of demand, cost and activity. And therefore, whether we have that very macro level intelligence to guide our transformation efforts, in terms of whether we, you know, we can, well, as much as anybody can be certain looking that long time ahead, but that, you know, we can be sure that our transformation efforts are directed at the most effective, well, or what will be the most effective areas. So, sorry to go from the detail to the big picture, but there you are.
Thanks, Anne. I'll start off, but again, others might want to come in. So last year's recovery plan, yes, we did have a significant amount that were balance sheet adjustments, and also some kind of cost control elements. The cost control elements, some of those did happen. They were just really hard to draw out because they are improvements in the services positions. But there are also deteriorations in the services position through locum costs, etc., etc. So we do know that some areas within the services that did improve. So some of the cost control measures did happen. They just play out in the financial position rather than us being able to articulate what they were. With regard to technical adjustments, a significant amount of that, there was around 4 to 5 million in there for annual leave accrual. We'd taken the assumption that we'd be bringing our annual leave down to 0. But I think there was guidance from Scottish Government towards the end of the year that actually said that we could again carry over up to 10 days. So that slipped our ability to give that strong message of, you know, no, and carry forward was very difficult. We still very much put out the message of we wanted people to use their leave for their well-being and that it's the right thing to do rather than it being anything around policy. So we did have, there was still some significant annual leave at the end of the financial year. So for this year, if that policy changes and it is everyone has to bring their leave down to 0, then yes, that the remainder of that accrual could be released. There's very little in our balance sheet now, so we have used the majority. There are still a few provisions that we have on our balance sheet that we don't know the outcome of yet. So there are some things in there that could play out in our favour, so we might have slightly over provided for. We've tried to be as prudent as we can within the financial position that we had. So it's tight, but there might be a little bit in there, but we're not talking the amount that we did have for this financial year. So hopefully that answers that one. The adult social care element within our plan, it's actually break even. We assume that adult social care will break even year on year. There is responsibility there for Highland Council to support the financial position, but there is a process through the integration agreement that we have to go through around that. So the plan, for example, this financial year, there's a savings plan of 4 million. So we need to work with the council to make sure that we deliver that. If it starts to transpire throughout the year that we're not going to, then there is a process that we have to go through to highlight that, to escalate a further financial recovery plan or to agree further funding if that is appropriate. But again, it would mean going through those stages. Within our longer term plan, know that you are right, it's around a 15 million gap, I think, the recurrent gap. That again is not reflected within our plan. So the figures that we've got at the moment just show effectively a break even within adult social care. I think the lead provider, I would say the lead provider model for us, it's possibly made us a little bit worse in the shorter term, in the fact that we didn't have the same level of reserves that other IJBs have been able to hold and maintain. So I just think that they're behind our curve, and that the other IJBs will catch up and deteriorate unless there is more money that comes out from government to support services. Just because I think they've got more reserves that have been balancing their position year on year. So we're starting to see the picture with some IJBs starting to show deficits, but there are not many at the moment. So yes, it's probably is deteriorating our position at this point in time. Longer term, I think that other health boards might catch up, but that's not really playing out yet. And I don't have the evidence necessary to support that either. That's more my feeling than fact. We are in the top 5 for worse financial position, but as you said, out of our 100 million roughly gap, I would say I think around 20 million of it is for the North Highland partnership element, which, as you say, doesn't include the adult social care. So that's a significant amount. So the other 80 is acute and corporate services. That brings us a little bit more in line with, it probably would put us, I haven't looked at the figures, but it would put us in more than just a top 5. I suspect there would be a few more added into that if we were comparing against that level. So the North Highland position does deteriorate us, definitely. But it also gives us some more opportunities to improve as well that we possibly haven't really taken full advantage of yet around the integration model. So there is benefits there that maybe others have already played out. From a national position, I think one of the benefits of having Scottish Government come in and do some targeted work with us will partly be around having another view and some resource to look at our cost drivers and to see what's really driving our position. Again, I think that without having the evidence behind it, it feels as if one of our cost drivers is due to a rurality and our need to provide choice. And if we reduced or removed choice, then our cost base would be less, but that wouldn't necessarily provide for a good service. So I think some of the work that it would be useful to do with Scottish Government is to look at that kind of cost of choice in a rural and quite a big geographical organisation and space. So that will be interesting. And that it will also be useful in Scottish Government being able to see where possibly some of our decisions, the difficult political decisions, could be taken, and where having our services maybe isn't adding the value that it should do, and being able to articulate that and have Scottish Government see that in detail might be helpful for us in some of the decisions that we might want to make in that transformation piece. And I'm not sure if any of my colleagues want to come in and support with that.
Thanks, Hilith. I think Boyd wanted to come in and say something, but I know that Pam would like to as well. So I'll bring Boyd in first and then Pam, if that's okay.
Thanks. I think just for the board and for any wider audience, I suppose the first thing to say is that finance isn't just a finance topic. The vast majority of our staff are clinical, and the understanding of the services we provide comes from the clinical workforce particularly, and those managers that support them. And so this has to be held across the organisation, and it would be remiss of me as the medical director not to bring that into this conversation. Transformation, efficiency, and I guess fiscal responsibility when it's the taxpayer's pound in what's a limited amount of money from government. It's so much, it's a lot, but it stops at some point. we have to balance all of that, and it does require those who really understand the services and the delivery of those services to the population, and who make many of the decisions day to day that connect back to the costs that Health has to then report in on. And so just wanted to really point that out and to say this must be held across all of us, and that particularly for me means that clinical workforce really needs to be a very involved part of how we move forward. The national discussions are very interesting, but we start from the point that we get about £1 billion from the government, and they are challenging us to what did we have to do, and it's for us to try and make the best of that amount of money with the workforce that we currently pay for and the services that we currently deliver.
Thank you, Boyd. Pam, you wanted to come in, please.
Yeah, and I think much of it's been said, but I suppose I think it's fair to say that the analytics from a national perspective that could, and at a local level that could support this, are not just as sophisticated in our system as we would like them to be for good decision making. But that conversation is going on nationally, and there is some work going on to try and understand that better, how that could be brought to the fore. I think Heleth would probably tell you, the experience in England in terms of how analytics are done and understanding value for money is probably quite advanced in comparison with maybe where we're at the moment. But there's definitely a desire to look at things in a different way, and certainly quite strong discussions about how that might happen, in some tests, I believe, underway. And I think from a local perspective, Heleth's trying to lead us into looking at the costs and to be much more, to use the tools that are available to us throughout the exec and senior management team. So there's a bit of learning, a bit of development going on there in terms of that decision making. But I think it's fair to say, in terms of the 3 horizons, there is a real expectation that we do try and demonstrate best value, and that we do try and promote efficiency in the here and now, so that we are doing the best we can to deliver what we can with what we've got. But a recognition that it has to be change that takes us to a different place nationally and locally to be able to do that. And that brings us right back to how we take forward our strategic ambitions in a prioritised and co-designed way, so that we take people with us, or at least we have the right discussions at a local level, that people understand the decision making. They might not always like it, but they understand and are maybe party to that decision making. So for me, the last thing I'd probably just emphasise, and I don't think I'm stating the obvious, this is a massive change of agenda. And for those frontline clinicians and practitioners, and whether it be in social care and health, to get their heads around that when they're feeling quite pressured is difficult. And, so part of this brings us right back to, what's the tone that we want to set? What's the supportive aspect of that, in terms of, recognising the challenges that we face, but how do we support people through that space safely? When we know that the pressures are such that it's hard to see the wood for the trees. So I think if we keep that in mind as we're going through this, then our conversations about change might be more helpful than if it's purely on there's just not enough money, you can't do what you want to do, because then people can become quite silo and quite protective. And so there is a different skill set required here. But equally, we also have I've met with many clinicians and frontline practitioners who do get it, but they want support to make the right decisions. And so we need to give them the door needs to be open for them to participate and be engaged. And then we also need to support them in that journey. So for me, the biggest part of this whole financial challenge comes back to sustainable, high quality services. What can they look like with the resources we've got? How creative can we be in that space? And indeed, how able are we to mobilise with our partners? And that's very easy to say, very tricky to deliver. But that doesn't mean the will's not there to try and do that. And right across, I still think we've got quite a way to go in our locality plan and in collective engagement of our workforce and communities. I think we've got quite a lot to do, and I don't think we're different from many places. We've still got a lot to learn in that space, and that shift to everybody's under pressure and how do we square it away to it's only us that's under pressure and them over there are just not doing their piece. So change agenda, people agenda, right at the front of this.
Thanks, Pam. That's sort of you've articulated, I think, something that I was trying to ask at the beginning around our culture and around it. So that's a helpful perspective. Graham has been waiting patiently to come in with a question. So Graham, I'll ask you to come in next, please.
Thanks. It's a narrower question, Helith, and it relates to an earlier mention about delayed discharges and the reduction in independent provider places available to us across the area. The implication is that trend is going to continue in terms of reduced supply. And we've seen already how that then brings additional cost back to us, the body, both through the health partnership, health and care partnerships, as well as the NHS. And I'm just wondering, first of all, it's hard to see how we're going to make any saving on that this year at all. But in fact, it would appear that it's probably going to be an increasing cost area in the year to come. And I'm just wondering, how you've done your forecasts on that topic across the provision of care, and are you expecting, or have you budgeted for increased costs of care because it's going to be provided perhaps by public bodies?
Thanks, Graham. Half and half. So when we did our financial planning, we looked at what we knew now. So no, we've projected in the areas where we knew we had lost independent care home providers, and that we were going to be running those as an NHS organisation and the additional cost of doing that. However, the flip side of that, and Pam Kremin might want to come in with a bit more detail, is around looking at the savings plan from a point of view of where do we invest more into the private providers to make sure that they don't fall over. So yes, you're increasing the costs on one point, but with the hope that you will reduce the spiralling cost or the increased cost that we have provided for, and also the level of agency cost that we've got at the moment as well. So actually the premium cost that we're spending on agency, by investing some more into the private providers, we could reduce that. What we need to do is model out what that optimum looks like, where we're managing both, where we're making the independent sector more sustainable, but also bringing down our cost base from where it is now. And there will be a sweet spot, I suppose, that we can hit on that. So that's part of that savings plan that Pam and the team are working through. Pam, if you want to come in with a bit more detail.
I can, just on a few minor points. We have been supporting providers with sustainability payments where they have met with us and outlined with their financial information around where they're experiencing pressures. Some of the mitigation work we've done is, for example, where we've had care home closures, we have been working across the sector to make sure that staff are gainfully employed and have opportunities across the sector with different providers, to try and shore up other providers who have been asking us for sustainability pressures. And we've also been working with providers around some agreed rates for different types of care. So a less rate than the optimal agency rates, if you like. So trying to develop a partnership with them around some capped rates around some of the services that we might provide based around individual people's care, more so than in care homes per se. So I guess there's a risk there that that might create an internal market, you know, so we just have to be very careful around the steps that we take and the parameters that we put around that, around non-disclosure agreements, etc., to make sure that we can work with providers in that way. So we're doing a number of different things to try and engage with the sector and try and manage costs from both our perspectives. One, to keep the independent service sustainable, so that we don't have to take on the home and provide a much more expensive service. Thanks.
Thanks, Pam. Okay, lots to think about. I'm not seeing any other hands up. I'll just pause for a moment in case anybody wants to come back on any of that. No, okay. So just to recap, we were being offered moderate assurance from the report that we've been provided with today. We were being asked to note and discuss the draft month 12 financial position, and critically approve the request for the brokerage of 16.272 million from Scottish Government, to enable delivery of the balanced position for last year, and also approve the financial plan for 2023-24, recognising that discussions continue with Scottish Government around actions to mitigate the financial challenge. Are members content that we move forward on that basis? Yeah, okay. Great. Right, I think we've earned ourselves a lunch break. Ever so slightly behind the schedule as per the agenda, but I'd still suggest that we take our half hour, maybe look a bit more actually, so maybe see you back here at 1:15. Fantastic, thank you.